Good morning, everyone. This is Margie Giuliano, the Medication Safety and Adverse Drug Event Lead for Connecticut, New Hampshire, and Vermont from the New England QIN-QIO, and thank you for joining us for today's webinar on a collaborative effort to enhance medication safety during transitions of care using pharmacy students. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. We will provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and I will provide you instructions on how to unmute your line at that time. Next slide, please. And next slide, please. Throughout this webinar, we will explore the program goal and design, including overview of the hospital pharmacist oversight role, the measurement strategy and results to date, along with how staff and patient perceptions have evolved, how one agency used initial data to obtain funding to expand and enhance their own program, and the recent modifications to align this effort with the National Action Plan to reduce adverse drug events. We will be transitioning among 4 speakers today, so I would like to take a minute to introduce everyone. Next slide, please. As I said, I'm Margie Giuliano, the ADE lead for Connecticut, New Hampshire, and Vermont from the New England QIN-QIO. Dr. Lemay is an assistant clinical professor at the University of Rhode Island School of Pharmacy and is responsible for coordinating the home health care student rotations with URI. Ginger also maintains a practice site with Rite Aid Pharmacy. Mary Biello is a registered nurse and a liaison for VNA of Rhode Island, and in that role, she supports safe transitions of patients. She has over 25 years in home care. Mary is also a co-chair for our Greater Providence Community Coalition. Marco Del Bove received his Pharm.D from URI and is preceptor to the URI student pharmacist under institutional, introductory, and advanced pharmacy practice experiences. He serves as the interim pharmacy site manager at Memorial Hospital of Rhode Island in Pawtucket, Rhode Island, and is a pharmacy clinical coordinator. Cynthia Stephanopoulos is a registered nurse and is the med safety lead and ADE lead for the New England QIN-QIO in Rhode Island. Next slide, please. During virtual learning sessions, it is so important for us to connect with each other. So please use our chat feature, which is located in the bottom right-hand corner of the screen, to introduce yourself and let us know if medication management is a focus of your care transitions efforts. Kathy Calandra will be monitoring your comments, weighing in and sharing highlights at the end of this session when we open up the lines for discussion. Next slide, please. Since many of you are already familiar with the QIN-QIO, I will do a brief overview to inform those who may not know who we are. The QIN-QIOs across the country work under the direction of CMS. The primary goal is to improve the quality and efficiency of health care for all Medicare beneficiaries. The New England QIN-QIO is led and administered by Health Centric of Rhode Island in partnership with Qualidigm in Connecticut. Together, they manage the 6 New England states. Next slide, please. For more information, you can visit our website at www.healthcarefornewengland.org. Next slide, please. I would like to do a brief overview of the Medication Safety and Adverse Drug Event Prevention Program that is part of the QIN-QIO scope of work. Next slide, please. Around the same time that CMS was awarded the latest contract in 2014, the Department of Health and Human Services released their National Action Plan for Adverse Drug Event Prevention. Within this action plan, they identified efforts to measure and prevent ADEs. They also identified 3 classes of medications primarily responsible for the majority of hospital-related events: anticoagulants, diabetes agents, and opioids. Next slide, please. One of the first things we learned when we started this work was that everyone was using a different definition of what an ADE was. We have adopted the definition by the Institute of Medicine, which defines an ADE as an injury resulting from a medical intervention related to a drug. ADEs are the umbrella in which adverse drug reactions and medication errors fall within. So those highlighted areas in blue are where injury or harm may have occurred. Those medication errors that are not shaded in can be referred to as near misses or potential ADEs. Next slide, please. As you can see, the statistics speak for themselves. There are many implications associated with ADEs, but the two major categories on our radar are the health system and patient implications. ADEs account for a third of hospital adverse events. They're responsible for approximately 280,000 hospital admissions annually. They cost the healthcare system approximately $3.5 billion in extra medical costs annually and account for 24.9% of hospital admissions for those patients over the age of 65. What really stands out to me is that about a quarter of all ADEs are preventable. So we can really look at this as low-hanging fruit in an area to begin working with our partners and providers. Next slide, please. Through our collaboration with providers and healthcare professionals, one of the gaps that has been identified is the lack of a proper medication reconciliation occurring at transitions of care. Next slide, please. Medication reconciliation is a process of creating the most accurate list possible of all medications a patient is taking, including drug name, dosage, route, frequency, purpose, and duration, and comparing that list against the physician's admission, transfer, and/or discharge orders with the goal of providing correct medications. Remember, patient medication lists are fluid and change constantly. We only know we're getting the most accurate information at the time of the reconciliation. We commonly refer to this as the best possible medication history. When done properly, the reconciliation is more than just comparing lists. The process should include ensuring that the drug is appropriate for the indication, the dosage is appropriate for the diagnosis, there's no duplication of therapy, and consideration has been given to drug interactions and other key indicators. Next slide, please. So why is MedRec so important? Again, if you look at the statistics, they speak for themselves. Medication reconciliation is a critical tool to impact med safety and reduce ADEs, especially in transitions of care. Next slide, please. So one of our goals has been to create cultural change within the pharmacy profession. We recognize that this has to start at the student level. We do a great job talking about ADEs and med safety, but students and pharmacy residents don't necessarily recognize the impact that ADEs have on patients and the entire healthcare system. To begin this process, we are working with the directors of pharmacy residency programs to help implement a statewide and then regional medication safety program. Some of the goals of this initiative are to develop a cross-setting medication safety program, embed processes to identify and track potential ADEs and ADEs, analyze data, implement interventions, and share information with pharmacists across the continuum. We've invited the regional colleges of pharmacy to collaborate on developing a webinar to standardize the med reconciliation process. This webinar can be used to educate not only pharmacy students, but also pharmacists and other healthcare providers who may not have been exposed to providing MedRec for a period of time. It is incumbent upon us that we ingrain this process as a basic and vital skill set so that our pharmacy students emerge with this knowledge and are ready to implement med reconciliation no matter where they practice. They will work directly with their preceptor pharmacists to ensure accuracy and confidence as they provide this vital service. This initiative will change the culture and practice of pharmacy, and our pharmacists will provide better and safer care to their patients. Next slide, please. So again, please use our chat feature to introduce yourself and let us know if you have implemented med reconciliation at your facility. We will be monitoring your comments, weighing in, and sharing highlights at the end of this session. I will now turn the mic over to Ginger Lemay from University of Rhode Island, who will speak about how she has engaged students in a MedRec program. Ginger?
Thank you, Margie, and good morning, everyone. It is my pleasure to share with all of you our program at URI. and the wonderful collaboration with the home health care agencies in Rhode Island over the past couple of years. This slide is a few of those students and residents who have participated in home health care, and just a favorite picture of mine. I'll give you a little bit of background about experiential education at URI and this rotation specifically that was developed almost 3 years ago, where we have taken it and where we hope to go in the future. So at URI, we have a 6-year Doctor of Pharmacy program where the first 2 years are pre-professional and the last 4 are the professional program. And within the 4 professional years, the students are required to complete over 1,700 hours of experiential education. The last year of school, like all schools, they have 6 6-week rotations in various practice settings, including community, gen med, ambulatory care, institutional, and 2 electives. And so we created this novel type of rotation for a variety of reasons for some of our students. So why did we create this type of rotation? This was definitely a unique practice setting for our students. They did not have much experience caring for patients in their homes, but we knew that this was a critical need for all of the reasons that Margie so beautifully laid out already, the importance of MedRec. We knew that medications are a frequent cause of hospital readmissions due to misuse and or non-adherence, and that MedRec and education are often time-consuming for the team members of the home health care teams, particularly the nurses. And we do know, and for those of you who have done home visits, you know that you don't know the full story about medication until you actually visit the home. It's not always what we see or hear at the pharmacy counter. So our goals for this rotation were to support the home health care teams, to provide students with experience in home care, and to identify and prevent medication-related problems resulting in patient readmissions. The students that we have on rotation, we partner with several home health care agencies in Rhode Island. Generally, we have approximately 5 to 6 students on rotation with a variety of different home health care agencies. Their experience is pretty much the same, although each home health care agency does have its own unique characteristics or personality. But in general, the student is assigned to a pharmacist preceptor, and that preceptor may be in an institutional setting, it may be an ambulatory care pharmacist, it could be a community pharmacist or faculty like myself, and we are their preceptor. However, 3 days a week, the student is assigned to the home health care agency and goes out with the team, usually nurses, but sometimes physical therapy or occupational therapy, or in the case of one home health care agency with a pharmacist, and they perform MedRec and provide patient education to the patients that they see. Again, the pharmacist is their preceptor. They are their lifeline for all medication-related questions. Any interventions or prescriber recommendations are run by the pharmacist preceptor, and we do also offer extensive drug information resources for our students while they are in the home if they need to look up simple questions. As far as our framework, we wanted to make sure, although we're working with a number of different home health care agencies, that we did standardize the rotation. So we have students and we have 1 PGY1 pharmacy resident assigned to the home health care agencies, and we provide an orientation process at the beginning of the 6-week rotation, and then we do a wrap-up meeting on the last day of the rotation, just to make sure that everybody's on the same page. And any previous students who've participated in these rotations are welcome to come back and share best practices, and we do include all pharmacist preceptors if they are able to attend. Topics discussed at the orientation include medication reconciliation, talking about transitions of care in the community setting, that often these are our patients who lack a direct relationship with their community pharmacist because they are homebound. We talk about the role of the student on the team, professionalism issues as far as attire, some real-life situations. Some of our patients may have dogs, they may smoke cigarettes, they may not shovel the snow in their driveway. So some things that the students can expect when they're going into someone's home. And then we also perform a student survey and talk about data collection. The student survey we provide to the students at the beginning of the rotation, and then we do a follow-up survey on the last day of the rotation. It's a 23-question survey. It takes them less than 5 minutes. It's on a 1 to 5 Likert scale, and again, it's administered at the beginning and at the end. And it asks questions to try to gauge the student's comfort level and confidence in caring for patients in different practice settings and also working with other healthcare providers because this is truly an interdisciplinary rotation. We also have 2 open response questions at the end, again, trying to get to the student's comfort and confidence with working with other healthcare providers, which although they do in the first 5 years, they may not have a lot of confidence in that area if they haven't done any rotations where they're working on a team. So I pulled out 4 questions from the survey just to share with all of you. The first one being, pharmacists play a role in healthcare in a home healthcare setting. Question 13, I'm confident in my ability to perform MedRec. Question 14, I'm comfortable caring for patients in their homes. And question 20, I'm comfortable seeking assistance from a nurse in a patient care setting. You can see the first column is before home health experience. The next column is after home health experience. We have the mean difference and then the p-value. Most all our questions did reach statistical significance. All of these, of course, did with a p-value less than 0.001. And you can see from before the rotation to the end of the rotation, there was a significant increase in their confidence and comfort level in multiple areas. We also have the students collect data. Again, they're at different home health care agencies, but they're all doing the same thing. So we wanted to make sure that the information that they collected was standardized and that we would be able to show the value of this rotation and also the value of having pharmacists involved. We developed this tool with health-centric advisors as well as input from all the home health care agencies that are accepting pharmacy students. And we've been able to go back and make some helpful tweaks based on some practical experience in the field. So let's take a look at some of the data. This is over a 2-year period. We started collecting the data in January of 2014. And over that time period, the students saw, this is just student data, they had over 1,400 patient visits. Of those visits, over 1,200 MedRecs were performed, so over 85% of the patients, and approximately 57% or 818 events of med teaching. This is broken down by semester. Spring 2014 was a bit of an anomaly. We had a few extra students out there. But in general, like I said, we have about 5 to 6 students on rotation, and they see roughly 30 patients per block. And again, it's a 6-week period where they're going out and seeing patients 3 days per week. When the students perform the MedRec, obviously they're identifying medication-related problems. We quantified them on our data collection tool as interventions. And these are the interventions that they identified. There was 932. The top 3 being adverse drug events, over-the-counter medication, and disease state education. Not all of the situations require a call to the prescriber. Many times this could be education to the patient or education with the patient and the nurse. And when that situation came up and the student recommended a change or an education to the patient, 41% of the time that intervention change was recommended. But sometimes it did require a call to the prescriber. The student never went directly or never does go directly with the prescriber. It's all through the nurse or the case manager. But these were the recommended times that a prescriber was contacted because a change needed to be made in the medication regimen. As far as the intervention severity, we asked the students to predict as a result of their recommended change what was impacted or prevented. So this could be anywhere from adherence support, which was the top category, all the way to preventing a life-threatening situation, also preventing an ER visit in a hospital readmission. So you can see even just with having students out there, we are making a big impact. At the end of the rotation, all the students are required to provide a educational presentation or in-service back to the home health care team. The topics have varied. Usually the home health care team will recommend a topic that they'd like to hear more about, and the students provide that 20 to 30-minute presentation at the end. We asked the students to provide a pre- and post-test to try to gauge the impact that the education has provided to the nursing or PT and OT staff. So we have 3 bar graphs here. The one on the left is average test score pre- and post-test. You can see in blue that the average pre-test was 71% and the average post-test was 95%. The bar graph in the middle is the percent scoring 80 or above on their post-test, and we were about 95%. And the percent increase in score from pre to post-test was over 80% had increased from their pre to post-test. So clearly, people are learning. And at the end of the rotation, we asked the students to write a reflection. Again, this is a rotation that many students have never had any experience caring for patients in their home, and we often say it's a very intimate setting. You're going into someone's home and caring for them, and sometimes it can be emotional for the students. They're seeing things they've never seen before. So I just wanted to pull out some of the phrases from this testimonial. This student said, "Aside from the services that I was able to provide, I walked away from this rotation gaining knowledge about healthcare that I would have never addressed in a community pharmacy setting." She went on to say how much the patients truly rely on and trust their healthcare providers, and she was able to connect with most of her patients on a personal level. She was able to determine what motivates them and why they may want to stay healthy and get better, and she felt the rotation brought her community experience full circle. Students who work in community or plan to work in community, this is extremely eye-opening. They do such a good job counseling patients at the counter that what they see when they get into the patient's home is often very different. And in my last minute, I just wanted to highlight one of the home health care agencies that we've been working with expanded pharmacy services, the visiting nurse service of Newport and Bristol County. The program history with this agency in particular, we've been almost 4 years. We've been working with them over this summer. We've had actually 12 students go through on home health care rotation, and we've had 3 pharmacy residents, Madeline, Corinne, and Tom. We've had 2 research projects based out of this home health care agency, a heart failure study, and also an ongoing study now with home med monitoring. As a result of the data that was collected from the heart failure study, which looked at improving patient adherence to heart failure medication and lifestyle modifications, and also being able to make a positive impact on decreasing rehospitalization rates for these patients, the data was published this past summer in JAFA. And as a result of this data publication, and the positive impact, we were granted funding to actually embed a part-time pharmacist in this VNF. With the addition of the pharmacist to the team, we expect to see a decrease in readmission rates, an increase in patient adherence, an increase in nursing time, an increase in patient quality of life and patient referrals, and hopefully a 5 to 10% decrease in readmission rates for high-risk patients. In closing, I'd just like to say we are all working very hard to help our patients. And this program has helped connect some of the dots with community pharmacists who are rarely notified when a patient is admitted or discharged from the hospital. And now I will turn it over to Mary Biello from the VNA of Rhode Island. Thank you.
Thanks, Ginger. The VNA of Rhode Island, we've begun the program approximately 2.5 years ago. At the beginning of the program, as Ginger had said, most of the agencies were hospital affiliated, but we are freestanding. So we relied upon URI's additional support in having a preceptor through the college to act as a mentor and guide for our pharmacy students. So we initially met with the preceptor to discuss our mutual goals and how the program could be beneficial to both students, staff, and the patients. Our rotations are set at 6-week intervals. When they come to the VNA of Rhode Island, we have an initial interview with them to try and understand what they're looking to achieve from their experience, as well as establishing goals and seeing what their topics for their presentation they'd like to have it on. At the end, we also have an exit interview, and those are always very interesting to hear the response that the students have had to being on the rotation. The students typically would meet with the clinician at the office, and then they would either go out together or they would go in their own cars out to visit the patient. That's an individualistic thing. They meet with the nurses at our agency twice a week, and then they are out with the therapist once a week. A field visit is flexible, so if the therapists are having more of an issue with a patient during that period of time, they could certainly meet with the student more than that once a week, and then the nurse would then pick it up just the once a week. Next slide, please. So the evolution of the program has been fantastic. There was a little bit of a mixed response at the beginning. Taking people out into the field can sometimes slow down the clinicians, but this has been such a collegial experience because the pharmacy interns bring a knowledge level that we appreciate so much. Med reconciliation is very time-consuming and can be overwhelming, even for a nurse or a therapist. So the support that the students have brought to us has been undeniable. Initially, the students might have been a little bit tentative about going into situations in areas of the state that they had not been before, but over the course of time, they've relaxed and they have become more open to the situations that they might encounter. They have talked to each other, and so now they have a more of an understanding of what home care is, and their anxiety, I think, has gone down. The patients from the beginning have been very positive. They've enjoyed having the additional support that the pharmacist has brought to their visits, and I think that over the course of time it's really given them a closed feeling of all of the entities of healthcare working together, and now including the pharmacist. In terms of the community physicians, we have had, and I think Ginger's data showed that, there's been some mixed response. Sometimes we get them to make the adjustments that the students have recommended, and sometimes we don't. But that's ongoing, and I feel as though as the program grows, we'll get more and more response in a positive way. The pharmacist presentations at the end of their rotations have been excellent. Initially, the presentations were geared towards medication classifications. For instance, there were presentations on benzodiazepines as well as SSRIs and anticoagulation therapy. Now we're moving a little bit more towards disease-specific presentations. The last student did a presentation focusing on the dual diagnoses of COPD and congestive heart failure. It was excellent and very well attended and received. Next slide, please. I wanted to do a brief patient story to really highlight the benefit that the program has had for us at the VNA of Rhode Island. Mrs. D is a 65-year-old female, and during the calendar year of September of 2013 to September of 2014, she experienced 15 rehospitalizations. She has several comorbidities that include congestive heart failure, COPD, diabetes, depression and anxiety, peripheral vascular disease, obstructive sleep apnea, obesity, hypertension, neuropathy. Suffice it to say, she has a lot going on. So we brought the intern into the hospital. I am a liaison, so I'm in the hospital frequently, and the intern came and made a joint visit with me and met the husband and the patient to introduce ourselves and explain what was going to happen. The intern was given a list of the discharging medications so that when the visit was made the following day to resume the patient back on service with the VNA, she was able to have already drilled down and see what might have been the issue. What she came to find was that there might have been some medication cascading going on, a new term for me, but very significant for this particular patient. So she was experiencing side effects of certain medications that she was on, and because of those side effects, that was adding to the number of medications that she needed to take. Her physicians were contacted, and they were receptive to discontinuing some of her medications, so that in the calendar year of September 2014 to September of 2015, this particular patient had only 6 rehospitalizations, which I know sounds high still, but 2 of those hospitalizations were for planned and scheduled surgical procedures. So I want to call it 4 hospitalizations, not 6. Regardless, it's still a more than 50% reduction in the number of hospitalizations. Now I'd like to hand over the presentation to my colleague, Marco.
Good morning, everyone. The topic that I will be discussing is the pharmacist's role as preceptor in home healthcare rotations. I'm going to echo a lot of the scenarios that Mary and Ginger had discussed already, but go into more detail about what the student's actual involvement or experience in the home is, as well as how they interacted with myself and integrated with me when they were on site within the hospital. Next slide, please. Next slide. So a little bit more detail about our rotation site at Memorial Hospital. Memorial Hospital is a hospital within the Care New England Health System in Rhode Island, which also encompasses Kent Hospital, Women and Infants Hospital, and Butler Hospital. The VNA of Care New England is our home health organization within the health system, and where the students complete their home health visits. I currently take advanced pharmacy practice students on their institutional rotations from the University of Rhode Island. I have 1 student per 6-week block, and I take the students throughout the year, so the summer, fall, and spring. And what we try to do at the Memorial Hospital of Rhode Island is provide a continuity of rotations for our students. And what that means is we have faculty and other preceptors at Memorial Hospital that will take students on their gen med rotations, on their institutional rotations, as well as some other ambulatory care rotations. So we try to set the students up with the University of Rhode Island so that they have back-to-back rotations at Memorial Hospital, so that by the time I see them on their VNA rotation, they have had full exposure to our health system. They're fully aware of our policies, procedures, our electronic health records. So really they get to see the continuity of how we provide care for our patients, and then on their VNA rotation, they now get to see them within the home. Next slide, please. So during the first week of their rotation, Dr. Lemay offers a orientation, as she had described earlier, and myself, I will provide them with an orientation to the hospital and to Care New England. And this is really where I go over all the details and policies and procedures that are required, but also going into more detail about the process for conducting medication reconciliation and patient counseling. And what I like to use as resources for this is the ASHP position statement that really talks about the pharmacist stand for medication reconciliation as well as counseling patients. At the VNA of Care New England, I rely on a student pharmacist champion who currently is Lois Hamilton at the VNA of Care New England, and they really are or she really is the student's champion while they are spending their time at the VNA. She will conduct a VNA orientation during their first week for the students, and she is really the go-to for coordination of the home visit schedule and introducing the student to the nurses or other providers that the student will be going out into home visits with. Lois is also available for follow-up and feedback with the student on patient home visits. And Lois also works with me to assign the student a final research project, and we've had a variety of topics that the students have been interested in and been able to present to the home health staff on. Next slide, please. So a little bit more about the weekly schedule for the students after their first week of orientation and settling in. Mondays through Wednesdays is where they spend their time at the VNA. One of those days will typically be an office day, and 2 days will be visit days where they're going out into the homes. The office day is the time where the student will review patient charts, follow up on any recommendations made previously. They can use this time to document their interventions that they've come across within the patient's home. This is where they'll also collect data and work on their final presentation, as well as being available to any provider questions. We've had nurses that really get to know the students and almost expect to see them there Mondays through Wednesdays, and we'll seek them out to ask questions about really anything that's come up on any of their home visits. And then when they go out on home visits, these could be an admission home visits as well as any follow-up visits for nursing care. We've also had students go out with physical or occupational therapists We've also had some experience where the students could go out for wound care or certain infusion services that the VNA of Care New England provides. Next slide, please. So on the home visit days, which over the past several rotation blocks have been Tuesday and Wednesday, the student and the nurse will visit 1 to 3 patients per day. It can vary. And the students will typically travel with the nurse to the patient's home. And this is where communication is really essential between the student and the nurse on coordinating not only visiting, how they will visit the patient to their home, but also how their plan of attack will be once they get into the patient's home. Next slide. So during the orientation, I really rely on past students' experience to educate and instruct my current student on how to strategize for the patient's home visit. And this, again, goes back to what I said about how communication is essential between the student and the nurse, because the strategy and how they would like to carry out the visit within the patient's home is very individualized. Some nurses prefer that the student go first or last. So what I've found has worked, and again, this is based on feedback from the students, is typically reserving the last 10 minutes of each visit for the student involvement and for the student to really interact with the patient. Upon entering the patient's home, the nurse knows to introduce the student and really ensure that the patient is aware of what the role of the student pharmacist is while they're in the home. It's also important to identify a caregiver if there is a caregiver actively involved in the medication, the patient's medications, and also on the flip side, kind of gaining what the level of the patient's involvement is in their medications home. And this is really where the student learns to adapt to the environment within the patient's home and also what their preferences are. Next slide, please. So in terms of medication reconciliation, we've talked a little bit about how MedRec is actually carried out. And again, what I've found to work the best is what I call the go-fetch method. And this is where when the nurse is conducting her visit, the student will ask the patient to go gather all of your medications from everywhere within the home. This is really where the student gets the eye-opening experience as the patient goes to their kitchen cabinet, their bathroom cabinet, their bedside drawer, their garage, wherever the patient may store their medications within the home. And when the student has access to these prescription bottles, the nurse can carry out her visit while the student performs their medication reconciliation. And this is where they're really comparing these prescription bottles to the patient's medication list that the student has obtained from their patient profile. The VNA uses McKesson as their electronic health record. And this is where they can actually conduct their medication reconciliation. Next slide, please. So what is medication reconciliation? We talked about what that definition is and creating the most accurate list that the patient is taking for their medications. So these are some examples of what the students have seen the most out on home visits. What I'd like to highlight is therapeutic substitutions or therapeutic interchanges, which some of you may be more familiar with the term. Therapeutic interchanges really come into play for the VNA of Care New England because they are transitioning from the hospital. And what a therapeutic interchange is when the patient enters the hospital, for example, if they are on a proton pump inhibitor of omeprazole, when they enter in the hospital, they will be interchanged by the pharmacist to pantoprazole as our preferred proton pump inhibitor as our hospital formulary. Now, fast forward to when the patient is discharged and on their med list, pantoprazole is listed, but when the patient goes home, they have omeprazole and sometimes a prescription for also pantoprazole. So this is where the student really ensures that therapeutic interchanges are not leading to duplication of therapy for that patient and really educating them as to why they were, could have been on one before and now on a different one after. Next slide, please. Patient counseling is another area where the students have really shown an impact on home health visits. And again, during that last 10 minutes, this is where they sit down and ask or review the medications with their patients and go over their medication list. And one thing that's always resonated with me and what the students have said that works the best is they ask the patient how they take their medications and what they expect from taking their medications. And this is really where you get the response that you can really work with in trying to educate the patient further on how they understand to take their medications. This is also the time for discussing compliance and adherence techniques. One thing recently from the VNA of Care New England side I've heard is that addressing side effects during this patient counseling session is really where the students can help the home health achieve their HCAP scores, or their home health consumer assessment of healthcare providers and systems. This is really patient satisfaction scores, and one of the domains within these patient satisfaction scores are whether or not the providers actually address side effects with the patient, and this is one of the areas in which the student has been able to show impact. And of course, the student is always there to answer any medication-related questions that the patient or their caregiver may have. Next slide, please. Again, some other instances in which the student has been able to provide education is assistance with setting up weekly pill boxes, identifying the indications for medications. This is really important. The patient may be on several different medications but not actually know why they're taking some of these medications. Scheduling medication times. The students have been actively involved in demonstrating proper inhaler techniques for their patients. Going through the prescription bottles and simply identifying whether or not something is expired. You'd be surprised on how many expired products patients hang on to for whatever reason. And this has really been something that the students have been instrumental in helping the patients dispose of these medications, but also obtain new prescriptions for medications if they run out of refills. Next slide, please. So on the hospital days, or the days where the students are with me in the hospital, typically on Thursdays and Fridays, and this is where the student not only carries out their institutional requirements, but also has their chance to follow up with myself. This is where they'll update and present their documentation tool of all of their interventions throughout the course of the week. We'll review any recommendations, and this is the time that I use for them to kind of go over any good catches, anything that they thought that went above and beyond or really helped the patient out. And this is where we can also discuss any clinical scenarios for new drugs or disease states, et cetera. Next slide, please. So more into what the pharmacist's role is. We talked about the oversight. I always stress during the first week to the student that I am available anytime while they are out on home visits. They can contact me by phone, by text message, by email, and I am there to answer any questions that they may have. Their immediate concerns in the home can be still addressed with the nurse or the provider in the home, but again, I am available on call for any questions that they may have. And the feedback loop for recommendations, we have discussed already, but the student is to compile their recommendations, share them with the nurse, and then the nurse will document these within her notes and share them with the prescriber for any changes and recommendations. And again, I'm also available to assist with the data analysis and any review of the final project and education that the student may provide to the home health site. Next slide, please. Just briefly talking about some recent developments that have come, the students have really taken some time in spending with our hospice care team within the VNA of Care New England. This is a unique population that has really been an eye-opening experience for the students. And also, as I mentioned earlier, medication disposal. Our current student is working on creating a leaflet that can be handed out to the patients in their home on really proper ways of disposing medications. As I had mentioned, there are a number of expired medications that they come across in the home, so this has really been instrumental in education of not only the patients, but as well as the nursing staff. And now I'm going to hand it over to Cindy.
Thank you, Marco. As everyone knows, the prevention of adverse events associated with medications continues to be a priority for professionals in all healthcare settings. The URI Home Healthcare Agency Pharmacy Intern Program has supported the National Action Plan through Aging e-surveillance during the medication reconciliation process at transition of care. The data obtained from the URI program has provided additional insight into the dangers faced by patients in the community related to their medication regime every day. The individual attention of the interns to the patients and caregivers also provides a great opportunity for communication and education related to medication management. This next slide demonstrates the addition of the high-risk drug classes to the screening tool. By adjusting the data collection tool used by the program for medication reconciliation, we have an opportunity to capture data related to the high-risk drug classes. This change will allow us to track these events, isolating the high-risk classes. In keeping with the idea of simple and feasible, it just requires a check mark to note if a potential ADE or an actual ADE, adverse drug event, was identified for each of the medications the clients received. This collaborative effort will provide information that may potentially improve patient safety through reduced adverse drug events. This concludes the presentation. We are ready for questions. Morgan, would you please remind people how to submit their questions?
Sure. If you have a question, you can press #6 on your phone to unmute your line. And while we wait for folks to get unmuted, Kathy, are there any questions in the chat box to go over?
I have a couple of interesting comments I'll read to you from a Samantha Saber. She said that she's a transitional care pharmacist and she completes comprehensive MedRec on admission, discharge, and communicates the information and changes and recommendations to the patient's PCP as necessary. And at her prior institution, she was able to implement a process for home medlist collection on admission in the ED for all patients being admitted via the ER from 7 in the morning to 11 o'clock at night by Pharmacist. We also heard from Lauren Arell, who is an RN embedded care coordinator for internal medicine. She has been assisting in transitioning patients from inpatient settings back into the outpatient setting. And Betsy Canino had a couple of questions for us. I don't know if you saw the answers in chat. She wanted to know if the pharmacy students go into the home with a nurse at all times. And the answer is they always are with a skilled staff, either a nurse, it could be a physical therapist, or an occupational therapist. And she asked how you deal with language issues if they don't speak English, and Mary has confirmed that interpreters are made available. Do we have other questions?
Again, it's #6 to unmute your line if you have a question.
Hi, I have a question. Hello?
Please go ahead.
Yes, go ahead.
Yeah, this is Priya. I'm a pharmacist at Coastal Medical. I had a few questions for you guys. I think this is a great program that pharmacy students have. My first question was, when students go into the home and they do the MedRec, are they doing the MedRec on the home health EMR, or like are they trained to use it on the EMR? Are they just kind of doing it there, and then the nurse would then do the actual MedRec in the system?
So for us at the VNA of Rhode Island, the nurse would do the actual MedRec on the EMR with the assistance of the student, but the actual med reconciliation would be done by the nurse or the physical therapist.
Okay, great, thank you. And then just in terms of the interventions, I was curious to know what portion, I guess, of the interventions do you think are related to, a MedRec error happening in the hospital, whether it was at admission or discharge, but then the intervention actually occurring because of that error?
I'm not sure if I'm able to provide actual percentages, but we have occurrences where, as you mentioned, there is a MedRec issue on discharge from the hospital that is identified by the student in the patient's home, which would lead to their intervention. But it's a smaller percentage, I would say.
Okay. Thank you. Priya, I can just add to that, too, with the VMS of Newport and Bristol County, where we have a part-time pharmacist there. We've actually just started
trying to get a better handle on that particular issue. So we're looking at number of discrepancies on MedRec. We didn't have that field for the students. I can anecdotally tell you that it's a lot, but I don't know specifically, where the breakdown is occurring. And that's what I was mentioning to at the end of my talk as well, is that a lot of this is happening unknowingly at the community pharmacy because we're renewing medication that the patient is no longer taking, but we were never told. So another nice piece is looping back in the community pharmacist. The students call pharmacies a lot and, discontinue automatic renewals of chronic medications and sort of clean up med lists at the community setting as well. So that's been a major benefit.
Great, thank you.
I'm wondering if there are others that have had experience in setting up some processes to communicate with the community pharmacists. Does anyone have anything to add from our participants?
Kathy, can you repeat that?
My question was, of our participants, I was wondering if others have put in place some processes to communicate with the community pharmacists, as we have always heard that there is a gap there with the community pharmacists, the retail pharmacists, I mean. So I wonder if anyone else had put anything in place.
That would be awesome. Thank you.
I can add something.
Okay, thank you.
This is Catherine from Concord. We're very new at this. I work in a senior center and I do public health nursing. And we're partnered with a local pharmacist who comes and speaks to seniors on occasion. And we're starting a program next month called Ask the Pharmacist. And once a month, there will be individual appointments available to seniors. They sign up in advance and they can come in and bring their medications and lists or anything around, medication or OTCs or vitamins, and be able to go through it and do some remediation, do some teaching. We're going to do 20 to 30-minute appointments. So that's new for us. We're going to see how that goes. And if you have any advice, suggestions, especially tools that are useful for people at home to recommend, I'm all ears.
Well, at the DNA of Rhode Island, what we try to utilize is teach-back with patients when we're doing med reconciliation. The teach-back method has been shown to be the most effective way to get people to understand what they're doing. So as a nurse, I would typically want to write everything down very neatly in my handwriting with times and reasons and have it all spelled out for the person that I'm doing the admission on. But that is not as effective as the person who is going to be taking the medication, actually writing it down themselves, establishing the schedule that works best for them, and then writing the reason and the side effects so that they have an awareness of what's going on. So that's one of the things that we've tried to, really incorporate into our med reconciliation process.
Thank you. Our director was considering doing, we have a little grant money, maybe purchasing some tools like, just the medication systems or home systems for people to try. But I really just feel it's kind of overwhelming with all the options out there, so I didn't know. I just wanted to, again, we're just starting it out, but I didn't know if there was any particular system that tends to be more popular with the older adults who may have trouble with dexterity or, sight or, any bigger numbers, for if it's daily, meds, just some of the obstacles that people run into with older adults.
Hi, this is Kathy. I'm a transition of care pharmacist at Charlton Memorial Hospital in Massachusetts. As far as your question about retail pharmacies collaborating, we actually have a retail pharmacy right in the hospital. And as a transition of care pharmacist, I actually do medication teaching while the patient is inpatient. Make sure they understand the disease conditions, the medication, and if there is any duplications and so forth, I actually contact the hospital list here. We also try to encourage patients to get their medications filled at our pharmacy right here in the hospital for two reasons. One, to make sure that they leave the hospital with medication on hand. Secondly, if there is any formulary issues, as far as medications are concerned, we actually initiate formulary exceptions or prior authorization requests. We do have prescription cards that at times we use, the discount cards or free month supply to make sure this doesn't inhibit patients being discharged at the timely fashion. But yes, we start the PA process to ensure that the adherence is addressed post-discharge. And if I have time, I actually call patients at home to make sure they were able to get their meds.
That's excellent feedback because our local hospital, I think, was looking into that, and I can check with the contact I have to see how far along they've gotten. Because what a wonderful program to have in place at the hospital.
Yeah,
Thank
this
you.
is pretty much the trend that all hospitals are looking at, and it's pretty useful. We find that to be very helpful for patients.
Thank you.
I have a question.
I would just like to remind who's ever not on mute that's not speaking, if you can mute your line so we can hear our question. Thank you.
So, I'm just curious about two things, logistically. Has anyone integrated occupational therapists into transition to care at the home meetings?
Occupational therapy has always been part of the transitions of care. I mean, they're part of our multidisciplinary team that's offered at the VNA of Rhode Island and at most home care agencies. So occupational therapy would be obviously one of those that would be most effective in people who have difficulty with inhalers, manual dexterity, being able to open the medication bottle. So they're frequently used with people who have medication-related issues in the home setting.
I mean more as an immediate collaborative effort between pharmacy students and maybe OT students or even certified occupational therapists. Are they ever in the home at the same time collaborating between one another with the patient?
Yes, occupational therapists are part of the team that goes out with the pharmacy student or intern.
Okay.
I don't know. I think at all of the settings, I don't want to speak for them, but I'm pretty sure they're all part of the team. The student goes out at the VNA of Rhode Island, they go out once a week with some member of the therapy team, whether it be the physical therapist or the occupational therapist.
Yes, Mary, that's true. At all the home health care agencies in Rhode Island where the interns go out, OT is involved.
Okay, so I guess my only other question would be, has anyone tried tackling or what sort of obstacles are being met with the billing changes that are now available to pharmacists with the incident to billing for transition to care?
We're not billing for, no, I mean, not specifically, there are no home health care agencies that have a pharmacist on staff currently. So we are trying, obviously, through efforts like this and through all the data that we're collecting and presenting to try to have more pharmacy services. So no, we have not done any billing to date. We've only had a part-time pharmacist on staff at one home health care agency since February 1st. So we're kind of in the early stages of that.
Well, everyone is.
So that's great, like billing is, sorry.
Go ahead.
My name is Jay Gupta. So billing is an issue, but I'm also wondering if we can have a system in which we can document the medication reconciling notes. Do you foresee that pharmacists will be able to log into the EMRs eventually and put their comments in there?
Yes, we have a pharmacist consult note for the pharmacist.
In the EMR or EHR?
Correct. Not the students. The students do not have access to the EMR and they do not exchange records for the patients that the licensed pharmacists do, the resident and the pharmacist on staff.
Great, thank you.
Thank you all. Thank you all for your questions. We are out of time. We don't like to go over because we appreciate that you took this hour. If there are more questions, or I do not see anything else in chat, so I will ask Morgan to just go over some final details. And again, we thank you for all of your comments and for joining.
Excellent. Well, thank you everyone for joining. Just a few things before you go. When you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill it out right now, or you're sharing a computer with someone else, you will receive an email tomorrow with a link to the evaluation, which you can complete at that time. The email will also contain a link to our events page where you can find the PowerPoint presentation from today. And then within the next few business days, a recording and transcript will also be added. So be on the lookout for emails about our next webinar in June, and thanks